Welcome to this educational module on the efficacy of the pericapsular nerve groove block versus the fascia iliaca compartment block for pain reduction and recovery following total hip arthroplasty. My name is Karina Gornez, and I'll be presenting this evidence-based discussion with the supervision of Dr. Valerie Diaz. The learning goals of this educational module is to help you understand the clinical importance and challenges of total hip arthroplasty, examine the current issues in postoperative pain, and understand the anatomy and physiology of total hip arthroplasty pain. Also, to compare and contrast advantages of the PENG block versus the FICB. Total hip arthroplasty, or THA, is a widely performed surgical procedure for managing osteoarthritis, with over 544,000 cases performed annually in the United States. However, approximately 20% of patients report poor postoperative pain control. This can lead to complications such as delirium, delayed mobility, and prolonged hospital stays. Elderly patients are at particular risk due to their sensitivity to opioids and polypharmacy concerns, making effective pain management strategies essential. Opioids are commonly used for pain management after THA, but there are increased risks for nausea and vomiting, which can contribute to patient discomfort, but can also delay recovery by limiting oral intake and increasing dehydration risk. Opioid-related complications can also lead to prolonged hospital stays and higher healthcare costs. And these opioid-induced side effects or inadequate pain control may require additional medical interventions, and this can increase the financial burden on both the patient and the healthcare system. Opioids also have a high potential for addiction, and prolonged use can lead to dependence. This is especially concerning given the ongoing opioid epidemic, where long-term exposure to prescription opioids can contribute to chronic opioid use and even substance use disorders. Delayed ambulation due to opioid-related sedation or muscle weakness can significantly impact recovery. When patients are unable to mobilize early, they face an increased risk of venous thromboembolism, which includes life-threatening conditions such as deep vein thrombosis and pulmonary embolism. Furthermore, impaired mobility hinders functional recovery, making it harder for patients to regain strength and independence after surgery. Regional anesthesia provides several key benefits in the context of postoperative pain management and recovery after THA. First, it enhances pain management by directly targeting sensory nerves. This allows for effective pain relief while minimizing systemic side effects associated with traditional analgesics. Second, it has an opioid-sparing effect. By reducing reliance on opioids, regional anesthesia helps minimize common opioid-related complications such as nausea, respiratory depression, and the risk of dependence. Third, regional anesthesia is cost-effective. By reducing hospital stays and minimizing postoperative complication, it lowers healthcare costs while improving patient outcomes. And lastly, regional anesthesia allows for early mobilization. Motor-sparing techniques ensure that patients maintain muscle function, enabling them to ambulate sooner and improve functional recovery. Early movement is essential for preventing complications like deep vein thrombosis and enhancing overall rehabilitation. Overall, these benefits make regional anesthesia a valuable strategy for optimizing postoperative recovery and reducing the risk associated with opioid use. The hip joint has a complex nerve supply with multiple nerves contributing to its sensory innervation. The anterior hip capsule receives articular branches from the femoral, obturator, and accessory obturator nerves. These nerves play a crucial role in transmitting pain and proprioceptive signals from the hip joint. Importantly, most nociceptive fibers are concentrated in the anterior capsule, making this region particularly relevant when considering pain management strategies for hip surgeries and interventions. The FICB is a field block designed to provide analgesia by targeting the fascia iliaca compartment, which is primarily affected by three key nerves: the femoral nerve, the lateral femoral cutaneous nerve, and the obturator nerve. However, a major limitation of the FICB is the inconsistent or incomplete blockade of the obturator nerve, which leads to residual and postoperative pain. Also, the femoral nerve is significantly affected in this block, which results in a high degree of motor blockade, leading to quadriceps weakness. This can be a major concern for early post-op mobilization and increases the risk of falls in patients. The success of this block relies on the effective spread of local anesthetic within the fascia iliaca compartment to reach all intended nerves. So proper injection technique and sufficient volume of anesthetic are crucial to maximizing its analgesic benefits while minimizing motor impairment. So let's delve into the pericapsular nerve group block, or the pain block. This technique is designed to target the pericapsular space, providing effective analgesia for hip-related pain. This block primarily affects three key nerves: the femoral nerve, which supplies both sensory and motor innervation to the anterior thigh and knee, the obturator nerve, which contributes to medial thigh sensation and motor function, and the accessory obturator nerve, which provides additional innervation to the hip joint. The articular branches of the femoral and accessory obturator nerves are located within the pericapsular space, specifically between the two anatomical landmarks, the anterior inferior iliac spine and the iliopubic eminence. By depositing local anesthetic within this space, the PENG block effectively targets the sensory innervation of the anterior hip capsule, which is rich in nociceptive fibers. This makes it an excellent option for postoperative pain control after hip surgeries while minimizing motor blockade, thereby facilitating early mobilization and rehabilitation. The PENG block offers several key advantages, making it a valuable option for hip analgesia. First, it has motor-sparing effects. The PENG block specifically targets the anterior sensory branches of the femoral, obturator, and accessory obturator nerves. By sparing the motor branches and posterior proprioceptive fibers, it helps maintain muscle strength, allowing for early mobilization and faster recovery. Second, it provides superior postoperative analgesia. Unlike some of the other regional blocks, the PENG block precisely targets all relevant nerves, including the obturator nerve, which plays a significant role in hip joint pain transmission. This leads to more effective pain relief following hip surgeries or fractures. Additionally, the PENG block helps reduce opioid consumption by providing effective, long-lasting analgesia. It reduces the need for opioids, thereby minimizing opioid-related side effects such as nausea, sedation, and respiratory depression. Finally, it contributes to a shorter hospital stay. With better pain control and preserved motor function, patients can ambulate sooner, participate in rehabilitation more effectively, and experience a faster recovery, ultimately leading to an earlier discharge from the hospital. The PENG block, while highly effective in providing postoperative pain relief, does have its limitation. One significant drawback is the inconsistent coverage of the posterior capsule, which can result in incomplete pain relief for some patients. This variation in block success is a concern, particularly for those requiring comprehensive pain management after surgery. Additionally, the success of the PENG block is highly dependent on the skill and expertise of the provider performing the block. The technical nature of the provider means that a more experienced practitioner is likely to achieve better results. Another challenge is that the PENG block takes longer to perform compared to other techniques. This extended time can be a factor to consider in time-sensitive situations, especially in a busy clinical environment. Finally, the lack of standardized protocols for performing the PENG block can lead to variability in outcomes. Without a consistent guidelines or training across practitioners, the effectiveness of the block can differ, impacting patient outcomes. Some key takeaways and clinical implications of the educational module is to show the effective pain control in the elderly improves overall recovery and reduces complications, ensuring better outcomes. Second, regional anesthesia is a safer option, offering targeted analgesia that minimizes systemic side effects. And third, the PENG block provides motor-sparing analgesia, enhancing postoperative comfort without compromising mobility. In summary, the PENG block is superior to the FICB. The FICB has been shown to have less targeted pain relief with a higher risk of motor block. The PENG block advantages are its superior analgesia, motor-sparing effects, reduced opioid use, and its effect on enhanced recovery.